and give us a little bit more of an opportunity to expand. And on these 2.2s, I would really, again, I guess you've got the emphasis, not have to tap these, because that makes that area less dense than the surrounding bone rather than more dense. Since we were minimally invasive with our punch, we're not going to have an ability to see a lot of bone. The flat surface right here, which is right at the crest of this tissue, right there, you can see, is 1 millimeter above bone. And so I'm fairly confident, because I can use my Explorer to probe around and feel the bone bilaterally, that we're seated. And hence, all this worry about trapping tissue underneath the abutment is just worry. I know I've engaged that cortical plate, because now this is getting very tough to move. And I think we've accomplished what we set out to do. We're going to now place our metal housings, black male inside. You want to seat it, and you want to make sure that it's seated completely. On occasions, if that doesn't happen and you don't seat it completely, pick it up. The patient may come back and say, I don't have the retention you promised me, and blame it on the system. But in fact, you need to make sure that you can visualize that seating completely. Because the thought would be we'd pick all the metal housings up and just remove the black males in the ones we're trying to keep, which would mean that would provide relief. And the ones that we're going to use as our sacrificial lambs would be the retentive mechanism. And in an attempt to do that, we may bypass it on this area, because I don't want anything touching this tissue right now, because that's the area of the least amount of attached tissue. We'll go ahead and see what it looks like. If we can pick it up, then we will. And a couple little tips here. When the tissue is where it is, sometimes you can't engage the undercut of the metal housing, and therefore it doesn't end up in the denture where you want it. But there's a couple things you can do. Since we're using a bisquicryl as a pickup medium, we can easily go in and place our resin, any type of flowable, to engage the undercut, and then we'll get a chemical bond, and a lot of times that will do give us the desired effect. Now, the patients come in, we've altered this area. We want to make sure that we have adequate space. Here's what we've done with the denture in those areas. And sometimes you may end up going through the lingual or the buccal, whichever the case may be, denture base, which is not a problem, because that can be repaired later. Our goal is to pick up the attachments, make the retentive ones be positioned in the denture as we want them to be, without putting any extra lateral forces on the ones that we're trying to secure long term. So how do we know we're all the way down? I could put it in like this, and I could say, okay, let's pick it up. It's great, no problem. But I may not be all the way down. That's why we took the bite registration. With this denture, it's going to be a little easier. However, if a negative ridge, as we mentioned, you're not going to know exactly if you are in the right position unless you had a point of reference. And that point of reference was the denture relation we took prior to anesthetizing our patient. So we'll put our upper denture in. We'll place our lower denture in with our, I find it easier to put this on the denture before you seat it. All right, go ahead and close for me by now. And we're close, but I want to, we're probably being held up over here, so how are we going to determine that? We're going to take the lower denture out and mark those spots again. I find it useful to make sure that you have the area of the denture here dry as possible so that we're not going to reincorporate a false area of reduction so that it won't run. And we want to dry around our soft tissue as much as we can because we would like to confine our markings to what? These abutments. And it doesn't hurt to go a little bit on the fascia because we don't want the denture hitting in this area. Remember, lateral forces are not our friend. We're going to let her close, open. We're going to put the registration in place. You might find it useful to put, as we didn't hear, a little bit more facial registration material so it locks. Go ahead and close for me. We still need to reduce some of the denture base, so we'll go back and have that done quickly and come back and get ready, prepare the site. We'll put our rubber dam material over the areas that we need to put it over. When placing these, you'll find it easier if you use something like a hemostat so you can control where you're putting. And all we're doing on this is basically, as you can see here, we've used a rubber dam punch, cut a little square, and this rubber dam goes between the male and female. Stretch it so that you're below the interface, and if you're not, then you go back in and make sure you are, because if you're not completely covered, you're going to prevent your pickup material from engaging the undercut on the metal housing. See how you stretch that, and it'll just lock in underneath. In this area here, we're not under the undercut area yet, so we'll just make sure we are. Now this is especially useful when you have made an incision, because it confines the pickup material to the area of concern, the abutment or the male retentive mechanism, and not in and around the bony area which we're trying to preserve for implant, for the implant to integrate, and also in this case the soft tissue. Okay, let's place her upper. Go ahead and have her close. Okay, we can confirm, we'll confirm with our bite registration, but we're hitting in the same occlusal scheme she had before, which is a lingualized occlusion with a little anterior open bite and from cuspid to cuspid. You can see how you can save yourself a little time by getting a little bit more of a guide with your registration material here. Okay, close for me right there. And we'll confirm, if you were made an incision to lay a flap, you're going to find that you've closed your buccal vestibule substantially, and you would have to relieve in this area. But since we didn't do that, it's nicely border mold, and it's going to keep the denture in the position we want. So now what we're going to do is just pick the attachments up. To facilitate this bite, we added some more registration so that it would lock it in place and we wouldn't have to fiddle with it as much. Then we've created an undercut in the area of the sacrificial lamb, so to speak, the 2.2s. Those are the ones we're going to pick up for retentive mechanisms. And then what we will do is replace the metal housings on the primary implants with just the black male without the metal housing, so that we have no forces placed on those implants. We've painted our retentive areas with dentin bond, dentin adhesive, unfilled resin, all the same material, to create an oxygen-inhibited layer. We will be using a bisque acryl ERA pickup, which does not generate heat, is stable with minimal distortion, so therefore we will be able to retrieve our male housing in the denture without causing any problems via heat through the conventional way, which would be the acrylic. We're going to bleed a little bit of the material out and we're going to inject around the metal housing that we're going to be keeping, trying to get in the undercut area. And over in this area, the same thing. We'll fill our housing in the area of the 2.2. Place our denture. Have our patient close. And we'll let it set. Give it about 2.5 minutes to set. We'll remove it. Take our black metal housing out. Reline around the other metal housings so we have a area where will be filled. We'll remove the metal housings on those primary implants, and thus we'll have a relief area so that they won't be under force during the healing phase. Our lower denture out, and when this happens where you don't engage the metal housing because the tissue level was right at the undercut area, it's real simple to take these metal housings out and reposition them. I'm not going to reduce tissue in this area at this point in time to pick that up, so I'll just do it and reposition outside the mouth. So we have the one that was reseated, and we'll go back and pick the other one up. We want to make sure that it does go to place, though. And it does. So we'll take this out and pick the other one up. So now we'll reseat this. Right, close very good. Hold it in place. We'll pick that up, reline, and add. As we're doing that, we'll go ahead and anesthetize the upper for her. Right, we've picked both of our male housings up with the black non-retentive laboratory insert. So we're going to remove that with our coring instrument. As you can see here, it just, I think you can see, it's hollow on the inside, just like a trephine burr, except it goes and cores out the center portion of the vinyl, which allows us to remove it without taking out the metal housing. Clear that out. Yeah. So you can see what it looks like when it's cleared. All we have now is the ring of vinyl, and we can go in with Explorer or 12 and clear that out for me so I can do the next one. And here's how simple it is to remove the black. And you take all this out. You can see the metal all the way to the bottom of the housing, or metal housing. And you want to try to get this out in one piece. You can use, this is a 12 blade, or you can use any small instrument to make sure you get underneath and pull that out. I was going to try to catch it for you. But now you see the metal housing is removed. I'll go and place a white, and we do the same song again. You'll need to clear that metal, center portion of that Dremel for me. This is the white, least retentive of our attachments, and it just will snap to place. Okay. We'll take the other black male out with our coring instrument. Did you remove that from here? And you notice I'm using a Dremel. It provides a lot more torque than the hand-driven or air-driven hand pieces, and I find that's much easier for removing these males. And this is how that comes out. And then we go ahead and insert our white. We'll try this back in, make sure it seats, and then we'll do our soft line, and we're finished with this portion. Last phase is to go in and reline the area of our primary implants to fill in the voids that you see here. And then we'll take our metal housings out and replace them with black males without the metal housings, which will create our passive load on those areas. The material we'll be using is the quicklime. It's a silicone-based material, so therefore it's not porous and doesn't pick up a lot of the things that will cause bad taste, etc. after a few days. Injecting just a bit in those areas because we do not want to get it into our retentive area of our ERA. Reposition, place our upper denture in. So now we've repositioned the lower denture with the upper denture and our bite registration. We'll let this material sit for 6 minutes, remove the lower denture, remove the metal housings that are on the primary implants. The 2.2s will be the retentive mechanism, also the vertical stops for her prosthesis until we get ready to restore the denture or the implants in about 3 to 4 months. We've incorporated the metal housing, imprint of the metal housings on the primary implants. We still have our retentive mechanisms in our secondary or our sacrificial implants, and we'll trim the flash off where we have flash of soft liner. The lower has been cleaned, polished with our soft liner, our retentive males in place, and our patient is ready to go. We'll have to bring her back in and teach her how to position this because a lot of people just bite their denture to place. We have to teach her how to guide it to place so that it follows the path of insertion and provides the retention we want. Close for me. And recheck our occlusal scheme so that it matches what was there before. And as a double check, we'll go back in. Open for me, Patricia. Close. So we're in the same position she was when she came in, but now she has her implants in place, and we'll have her back tomorrow morning to verify that she can remove her denture and place it back in a passive way and check for any overextension or sore spots on her upper or her lower denture. What we want to do is make sure that our patient leaves this in overnight, the denture, because if there's any swelling, she may have a challenge getting in place tomorrow. And we've made sure that the denture is secure and stable before we release her. She'll be on a soft diet. She'll come back in tomorrow, at which time we'll rinse the denture and make sure she is able and capable of placing the denture comfortably. Because she's been here for a while, if your patients are sedated, they may think they understand what to do, but they don't. There's one or two exceptions, and that's patients that are have Parkinsonism and a hyperactive tongue. In those patients, I keep the denture because we want to make sure that when it's seated, it stays seated overnight. And I've had on more than one occasion with a Parkinson's patient that not be the case. So I've elected to go with those folks that have moderate to more advanced Parkinsonism, where the tongue is not a controllable feature that they have. We don't give them the denture until which time we feel soft tissues healed. And in those patients, I would not have the superstructure on. I would probably bury these implants, let the tissue grow back over, such as it would be, and come back at a second stage and uncover it, so those implants wouldn't be subjected to extra force. Well, in review on Patricia, what looked like a very easy case had pitfalls. Had we not done a CT scan, we would not have been able to identify the significant buccal undercut on the upper and the undercut on the lower, which would have possibly made our case much more stressful. We identified those, and in fact, had we not had the stent, we would have, where the undercut was, we probably had 3/4 of a millimeter on each side of the implant. And unless you're extremely lucky or very, very talented, the chances of going in there and doing that without a guide of some sort would be something that you wouldn't do on a routine basis consistently. We're going to see Patricia tomorrow. We've relieved the buccal area on the upper denture because in placing these implants, as you saw, I didn't seat them all at once. I placed them and I went back one to the next, and came back and continued driving the implants in. In doing so, we expanded the buccal plate in the undercut area approximately 1 millimeter and probably 1/2 millimeter on the occlusal surface, or the occlusal area of the osseous interface. And keeping in mind, if we had if we don't relieve that area, that will possibly be a source of non-integration. So we're very, very intent on getting all pressure off of the denture in the buccal undercut area. On the lower, we picked it up with 2 ERA white males, or our retention mechanism. We then went back and relined over our primary implants, which had their metal housings in place. Once the soft liner set, then we removed the metal housings on the primary implants and replaced it with the black male without the housing, which now we have established a passive area or a relief area, so those implants are no longer under function. And the last and probably the most important part of this whole situation to create predictability is to make sure that the occlusion is such that when the patient goes side to side, we're not going to be torquing these dentures, because at this point, it's not the vertical forces that will cause non-integration, it's the lateral forces placed on these implants during healing. And on the upper, you notice that we did not place the angle correction. We didn't place the angle correction because we will most probably see the tissue grow over the top of those implants, and they will be, or that tissue will be our litmus test to see if we're having pressure placed in the area. What would that mean a month down the road if Patricia comes in a sore spot over one of these areas? That would let us know that the denture is putting sufficient force on the tissue to allow it to be pinched by the implant. And so it's not a subjective thing. Patricia will know, I need to get in right now to have this adjusted. After we make 1.5 months to 2 months, we're pretty much in the clear. However, I will probably suggest that we leave the upper implants in at least 4 months before we try to come back and load. So in that case, we would do both the upper and lower in about 4 months. We'll see Patricia tomorrow. She'll be on a soft diet tonight, and she will go home with her dentures in her mouth because we've stabilized them, so I'm confident that they will remain in that position until tomorrow, so that if there is any swelling, we'll be able to seat these dentures back properly for her. Four months ago, we placed implants in Patricia's upper and lower. She's back now to have the denture connected via the ERA abutment to the implants. We've taken a denture relation so that when we pick these implants and this complex of ERA, denture, and implant up, it will be in the same position that her denture is presently. We've had 4 months to work out the occlusal scheme to make sure that we're happy with the occlusion and she's happy with the aesthetics. So at this point in time, it's just now connecting the dots. So let's review what we had done previously. We placed 5 implants in the maxilla and Patricia and 5 on the lower. The difference being on the lower, we were able to parallel those implants and angle correction was not necessary. So when we completed the lower last time, the intermediate implants, the 2.2s, were loaded to retain and protect the primary implants, the midline and one on each side, from the trauma of the denture. From the trauma, a very narrow ridge down there, the bone quality on the lower was about equal to the upper. And so therefore, those were done, picked up, and she left along with her maxillary denture, which was not engaging the implant. She had a nice vault which had good retention, good stability, and prevented the denture from sliding back and forth and laterally, which is what causes the problem with these thin implants. If you have a flat palate, it's going to require you to place something in there to prevent those dentures from going and creating lateral problems for the implants. We had Patricia back, this is 4 months now, to do the upper because I leave the implants in the maxilla due to the quality of bone there in for at least 4 to 5 months before we uncover them. We went back and took our denture relation so we can position the denture as when she came in so that when we pick the attachments up, they will then be, she'll leave in the same position. And if you bypass that step, you'll do it one time and get a cant to your occlusal plane, and you'll know that it's a very, very important step. So we did that. We uncovered the implants using the surgical guide that we had from the CT scan. If you don't use a surgical guide, at the time of surgery, you need to identify where those implants are. So it's a good, at that point in time, to go ahead and take an impression of the implant or of the upper before you release the patient. When you do that, you can do a suck down stent and make your guide so that 4 months later when she comes back, you'll know where your implants are. Well, with Patricia, we identified where the implants were, we uncovered them, but we did a little extra procedure. Her frenum was attached to the crest of the ridge, right on in the midline area, right near that midline implant. And so when we uncovered this implant, we decided to relieve and move that frenum attachment superiorly about 4 millimeters. And that took a little bit longer. The reason we did it at this stage rather than the other stage is because we wanted the blood supply, we didn't want extra trauma in the area, and it was bound down. Now we've opened this up, and there is the potential for that frenum pool to do something to the keratinized tissue that surrounds that midline implant. So after we've done that, then we go through the process of determining the path of the prosthesis, and we'll look and see the most angled of the implants should be the one that we start with, and we'll use a combination of angle corrections so that we have the minimum correction for all. I would rather have some 5s and some 11s rather than some 5s and 17s. But this also illustrates why this system and this attachment specifically allows us to do this without a bar, because with Patricia there would be no way that we could place these implants and have predictability 6 months, 5 years, 10 years down the road, because we would not have the path of insertion that was parallel. We would not have the vertical resiliency, and the lateral forces that would be placed on these implants in this thin bone would be detrimental, and ultimately the prosthesis would fail. But as you saw, we were able to correct the path of insertion, pick the attachments up, put a retention final prosthesis that is comfortable for the patient. What Patricia's going to realize is that she'll have no plastic in the roof of her mouth. And as you saw, the denture was very nicely done. The tissue anatomy reflected that of the patient. So in Patricia, we may not even need to bring that buccal flange over anymore. We can feather that in because we no longer need that to give us retention because we have the implants. And what I'm saying there is that because of her extreme undercut in the anterior region, it placed some resin underneath her nose and plumped that tissue out. And we were having a little bit of a trouble with that when we were picking our attachments up. When they go back, they may bring that to where the undercut starts, feather it in, and now we have something that gives them an aesthetic look and still provide the retention. The nice thing about this system, if you follow the protocol, it works. And if the patient is there to have something done, if they get involved with doing what they need to do to make it work, then your success rate is going to go up, your stress rate is going to go down, and these folks, it is really, truly a quality of life issue.
It's been a great experience. I've been working with a dream team. Now I feel like I'm getting back to where this is just a part of me, and it feels really, really good.
We hope you've enjoyed this program. For National Dental Network, I'm Vicki Hudson, and thanks for watching.